Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Carrie Ruller. Today, we're talking about something that affects so many patients, but often isn't treated the way it should be: chronic pain. I'm joined by Dr. Ryan Budwany, an interventional pain specialist and chief medical officer at Pain Health. In this first part of our conversation, we're diving into why so many patients feel stuck, why pain is often managed with medications instead of actually treated, and how delays in care can lead to long-term loss of function. If you or someone you care about has been navigating chronic pain, this is a conversation you don't want to miss. We're going to split this into 2 episodes because we had such great conversations. So here we go on the first. All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Carrie Ruller, and today we have Dr. Ryan Budwany. Welcome to the podcast.
Hey, Carrie, thank you for having me. It's such an honor and a pleasure to join you. I've heard from so many of my patients that they get such great benefit from listening to you on a weekly basis or every other week. So thank you for doing this for our community. I appreciate being here.
I'm so happy to hear that. That's the idea, right? Feedback to the community and obviously just educate patients, clinicians, everybody. So I'm happy to hear that feedback. So a little bit about you, obviously, because you're our spotlight today. But anyway, you are an interventional pain specialist and chief medical officer at Pain Health, who is really at the forefront of combining AI, minimally invasive procedures, and regenerative medicine to help patients move beyond masking pain and actually restoring function. So those are some of the highlights and expertise of you. I could go on and on about your resume and all the wonderful things you do, including like international help and everything like that, and speaking at conferences. But if you want to add a little more about who you are and what you do, why don't you share that with us?
Sure. So again, thank you for having me, Dr. Ryan Budwany. I'm an interventional spine and pain physician in Southwest Florida, serving the Tampa area and beyond. I actually have a really unique practice and background. I got all my training in Appalachia, and then we moved down here for family. And people wonder why Appalachia. That's really the center of modern interventional pain care. So I work with my mentor up there, Dr. Tim Deere, who's like the Einstein of our field. So a lot of the innovations we'll talk about in this talk today, we've actually developed in our offices there. And really the goal is to transform the way patients not only experience pain, but how they also recover from it and then get back to their functional lives. A lot of technology is involved in helping to assist them getting to that level of care. And why the Tampa area? We have family here. It's a wonderful area to be in. And honestly, there's so much need from our patients to get access to this kind of care. So I think it's such a great time for us to be part of this community and to serve our patients and hopefully optimize their experience so they can enjoy the beautiful environment around them.
Yeah, I love the way that you said that. And I think one of the things that I want to highlight from what you said, because I think we're going to talk about that a lot, is the access to care and how we can better that for patients for sure. So, why do so many patients wait until pain becomes disabling before they seek advanced care?
It's such a great question. I think that patients just aren't aware of
Mm.
the options that are out there. And I think just the mindset that we need to provide care or get access to care or get a therapy done or surgery done only when the pain is so bad that now it's a life or death situation or a debility situation. And what I tell my patients is let's step back a little bit, right? Come in sooner and figure out, okay, if I'm not able to walk down the block like I used to, or prepare a meal for my family or work like I used to because either I'm having back pain or neck pain or whatever else is debilitating my ability to do the things I used to, then our body is basically telling us that, hey, there's something else that's going on here. Pain is, if you remember, right, they used to call it the fifth vital sign. And that kind of created some of the issues around pain that we deal with. But pain is also an indicator for the body, right? It's telling you that, hey, something's not right here. We need to try to figure out how to address this. And so I often tell my patients that don't wait until it's too late, because if you wait that long, then something that could have been handled by an extremely minimally invasive approach, such as an injection or physical therapy, chiropractic care, now has turned into something that's going to require large surgery. And so, again, that's with anything, right? If you start having chest pain, for example, your body is trying to tell you that there's something else that's going on. Or if you have a history of diabetes in your family and now you're noticing there's some changes happening. Again, if you wait till it's too late, you end up with the long-term consequences of that. So pain is very much like that. But the thing is, it's not just pain, it's the structural of your body, right? It's the musculoskeletal system. So the way your muscles function, the way your bones function. So everything you do, all your movement ties back to that system. And so you don't have to be 80 years old to experience pain, right? You can be 30, 20, 50. You can have a full spectrum of ages in your life, chapters in your life where you're experiencing different pains because of things that are happening. And I think our physical function is really tied to getting better and making sure that we're aligned completely so that we can get better.
Are there any examples of what things that you might see when patients are coming to you too late?
So, absolutely. I'll give you an example really, spinal cord stenosis. That's a very common problem that we see. So, what this means, again, it's not a scary term. A lot of patients are going to, what we call as a positive shopping cart sign. And so when these patients come in, they're coming in and they're like, hey, doc, I can't even walk to my car without having to sit down. Or we call it positive shopping cart sign because if they're shopping around at Target or Publix or something, they're actually having to lean on that shopping cart to get around. My patient will tell me, hey, doc, as soon as I get to the grocery store, I need to find that, that shopping cart and lean on it to get around where I'm going to. And you'll see these patients the next time you're around out there. But now the thing is that, what's happening is the spine again, it's a very dynamic structure. And as it ages, there's a little bit of compression that happens if there's misalignment. And so the nerves there start to get compressed. And when they start getting compressed, it's the best way to think about it. It's puppet strings like on a puppet, right? That you're trying to move the legs and the feet and the hands and so forth. And so when those nerves get compressed, your ability to lift your leg up can get impaired. And the only way long term, if you keep denying getting care for this, is going to be actually a full blown surgery for your back. And so if you come in sooner and we identify this with appropriate imaging, with appropriate physical examination, then we can figure out, can we use injections to help solve this, or can we use minimally invasive options to solve this? So again, we do most of our work through the head of a needle. There is really no major scarring or anything like that because everything we're essentially doing is to the head of a needle, but we use everything based on image guidance under fluoroscopic or x-ray guidance in our office or under ultrasound guidance to make sure that we're providing precision or precise care. And again, I stress to my patients that if you wait too long, it's not just that your body is getting worse, but the things that you used to enjoy doing, say working out or going to the beach, on walks with your spouse, if you stop doing those things, then again, you're going to start adding on weight, right? Because the calories you were burning, you're no longer doing that, right? Or the things you used to enjoy that would help you mentally relax, right? Enjoying like that long walk on the beach. If you're no longer doing that, then it also affects your mood. So pain and the way our body functions, that structural portion is not just tied to that one symptom. It ties into everything else that we do. So that's why whenever you're with your primary care doctor or your physical therapist or your chiropractor, think about these things that what am I not able to do now? And what structures are really basically sending that fire alarm signal that, hey, I'm in too much pain. I can't do this anymore. And that's what our goal is in the community to work alongside our patients to hopefully improve that care.
I love that you brought in the mood component because that's exactly what I was thinking as you were speaking about not doing things like not moving as much to be gaining weight and the adverse outcomes with that. But I was thinking like, okay, you're telling me I can't work out. I can't go for a walk with my spouse or significant other. Then yeah, that's going to affect anxiety, depression and things like that. And we know that patients that have more pain have some of those mood problems too, and vice versa.
Absolutely. We're in such a beautiful community, right? And we have beautiful nature around us. Not everywhere in the world has this kind of access, right, to the beach and to the bay and so forth, right? When I was in Appalachia, we did a lot of hikes up there, right? It was beautiful, but again, we had a lot of cold and messy winters with a lot of snow, and we didn't have access to nature like we do here. And again, that's one way to solve a lot of these problems is to try to stay active. But when you're trying to be active and your body's telling you that you're not able to do something, that's a red flag there. And that's why I tell my patients that, hey, try to address this sooner. Let's figure this out because, again, your body should be able to function well. And if something's going on, right, then that means there is some trigger that's happening. We should be able to pinpoint what's happening so it doesn't become a long term obstacle in your day to day life.
Why has pain care historically been so focused on medications in the past?
So that's a wonderful question. And I'm going to go back to, where I did my training at West Virginia University in Appalachia. Part of it is those are the only tools we had. And a lot of the patients that I had back there were coal miners, right? They worked really hard, work on their body was really hard as a result of that. And that long and hard work really broke down that body. And unfortunately, these patients, all they wanted to do was work to provide for their family. And so when you work so hard, and again, it took an effect on your body, the only thing they had access to was medications at that point. And so those medications is what they use to continue to provide their day-to-day care. But the problem is that when the body is signaling I'm in pain, it's not telling you that take this pill and turn the pain signal off. It's not that simple, because then all you're doing is basically masking that fire alarm. There's a fire still happening. There is smoke still happening. And just turning off the fire alarm or ripping it off the ceiling so you don't hear the little noise all the time, it doesn't mean that the problem is gone. So that's very much like what pain pills do, right? Or any medication for that matter, right? Medications are there to basically tell your nerves that, hey, ignore this problem, and then the pain is no longer there, continue to function. But pain is there because there's something wrong with that structure. And so as the tools have evolved over the last 20, 25 years, now we've actually are in a really unique and transitional point in the field of interventional pain and interventional spine. I consider myself an interventional pain and an interventional spine specialist. And what really that means is that now I'm using these advanced tools to hopefully solve the underlying causative agent to the underlying pain. So we go back to that spinal stenosis example that we talked about, right? If you're having issues with movement, rather than just doing injections or just taking medications, you can come in and do minimally invasive procedures, right? Again, to the head of a needle or through a penny-sized incision, less than about an inch to half an inch, where you can go in and put a spacer in that spine. And if you have basically the spine is bone on bone, you can go in and open up that structure and hopefully solve that problem. So I can give you an example. I actually have a spine model here, so I can show you how that would look for our viewers that are able to see me. Basically, if this is the spine model here, and if this is your spine, if you didn't have the spacer in here, you'd be essentially bone on bone. And so what that would mean, and I can show you the structure above, is that if this structure is completely compressed, you have no space there. And so if you have no space there, then what happens is it's compressing those nerves. It's compressing those nerves that are helping you move your legs or move your feet and so forth. And if that's the case, nothing's going to help improve this unless you can go in and actually open that space up and stabilize it. So that's what this spacer that you see here allows you to do. So this is one way that you use a minimally invasive approach to taking care of this. And I say this because, again, one of the approaches we do for our patients when they come in, we do a very thorough physical exam. We look at what the imaging is telling us and how that corresponds to their day-to-day function. And then we start off with diagnostic injections. So we use injections to help us identify and pinpoint exactly, precisely where that pain is coming from. And we're doing all of this under live imaging, like we talked about, under x-rays or ultrasound. Once we've identified that, we want to see, okay, how much pain relief did they get? And was this long lasting? So was this just a temporary issue where they just had a irritation there? And whatever medication we put in, typically we use steroids, like a cortisone shot essentially for the back, some lidocaine or bupivacaine. Again, these are numbing agents to see, can we calm the nerves down? And if we're able to, and that turns the pain signal off long term, that's excellent. But if it turns it off short term, and they still get good relief, but the pain starts coming back, then what it's telling us is that there's a structural problem. And for a structural problem, you need to figure a structural solution out. So this is very, very much like the fire alarm analogy that I was telling you, that yes, we have medications, right? Whether it's oral or injection-based medications that can temporarily turn off that fire alarm. But if there is indeed a fire, we need to figure out how do we solve this? Because otherwise you're going to burn the entire house down, or eventually have a debility or disability because you've not corrected that issue. So that's the mindset by which I tell my patients that, hey, look, when you're experiencing pain, your body is giving you a signal that there's other things that need to be done in order to improve your long-term functional outcomes. And in my practice, we're a predominantly opioid-free practice. So we don't prescribe any oral opioid-based substances for long-term management, because I want to work with my patients to figure out what can I do to actually structurally fix this problem. And this, by doing it this way, we really reduce the side effects, right? Because a lot of people become dependent on these medications. That's what led to the opioid crisis. So, right, you asked, we had medications, this is what we were doing. Yes, these medications helped, but they had so many more side effects that the medications themselves left people handicapped. And they were so much reliant upon it that they could no longer clearly function in their day-to-day life.
I think in medicine in general, hopefully, right, is turning away from this approach of just putting a band-aid on everything. And I think that clearly the interventions and the new technology that's been developing, especially in your field, is really helping us move away from that. So they might have been limited previously, but they didn't know what to do, know what other procedures or things to do. But I liked your analogy with the fire alarm and things like that. And I think of it like of your body spikes a fever, right? Your body is telling you something is wrong. Either you need to rest or seek treatment or take an antibiotic or something, like something's wrong, right? And listening to that, I think, is super important. And I think when we were talking before, it was very important for you also to mention lifestyle things that, are needed to be, I don't know, prescribed, if you will, like to help get better, even with pain. But also, like you said, with diabetes, we don't really just give the medicine. We also want to educate the patient on their condition and teach them and show them that other lifestyle changes between like sleep, exercise, stress, nutrition, all these things are very important as well, rather than just, okay, here's a metformin or a new GLP-1 or something like that.
Exactly. It's not a band-aid approach, just, you're dealing with that. If you have high blood pressure, you're not just telling people, hey, just take this pill, right? Or if you have high cholesterol, you're not just telling them to take this pill and solve the problem. Very much, right? Pain is like the check engine light in your body, basically saying, hey, this is an issue, right? I may have low tire pressure or whatever. I need to get this addressed. And if you don't get that addressed, right, your tire could blow out. Similarly, right, your discs can blow out. And then it becomes a full-blown problem that requires really a larger spine surgery. And so again, there's multiple ways to solve this, but you would want to try to catch it sooner before it becomes a long-term issue where it requires significant more time in recovery and you're out from things that it takes longer for you to go back to the lifestyle you wanted, whether it's returning to work or going back to exercising and those kind of things.
You mentioned something very important with your approach doing the injections and things like that, because I will have patients come to me and be like, oh, the injection didn't help or whatever. And I'm like, think about it from your perspective. It's not just the therapeutic procedure, it's also a diagnostic procedure. So really understanding maybe why something failed is super important, and why they should actually continue to follow up with a person like yourself so that they can go to the next step, whether, if it didn't work or not. So it's not just therapeutic, but it's also diagnostic, like you were saying.
Absolutely. So I think a lot of the work that I do, I mean, I spend a lot of the time educating my patients. Accordingly, my staff does the same. And I want my patients to understand that, again, just like checking your blood pressure that you do in the clinic, or checking your sugars for diabetes or your cholesterol or your EKG, these are all diagnostic things. So we need to identify, especially in pain, right? We're identifying things at the nerve level. So we're checking nerves, right? We're checking one or two nerves out of 30,000 pain nerves in your body. And so in doing so, we have to be very precise. And we don't want to turn off all the pain signals at the same time, because we're not going to know exactly where the pain is coming from. Because again, it's precision-based care. And once we've identified that problem precisely, then we can come back and say, okay, you know what? We've done this injection. You got good relief. Even if it lasted several hours, it only lasted several hours because the duration of these medications only lasts for several hours. Then we can come back in and do other things like radio frequency ablation. That's a special kind of injection we do. Basically, we use an electric needle that turns off the pain signal, and that can turn that pain signal off for about a year to year and a half. But again, all that's simply doing is just turning that pain signal off. So the way I like to explain it to my patients is, if we turn that pain signal off, we've really given you a gift, okay, in that short period of time that, okay, you don't have pain. That doesn't mean you go back home and just sit on your couch more comfortably. You go back and work extensively with that physical therapist or that chiropractor and do those lifestyle modification things. So if that means that you need to take a little bit of extra weight off so that your body doesn't have to bear that extra weight that's causing that pain, or change the way you walk, change your posture, change the way you sleep or the kind of bed you're sleeping in, all of those things, you have that little window that we've given you because we've turned that pain signal off, so you can actively take part in exercise and those kind of things to hopefully reduce this long-term onset of pain.
I don't know if this is a dumb question, but you were showing us the spacer before. Now, is the spacer something that you would put in, or is the spacer something more like a neurosurgeon would put in?
So a lot of these technologies, we actually in the field of interventional pain management are putting in ourselves.
Okay.
And I want to go back to a different example, but where interventional pain management is today is where cardiothoracic surgery was about 20, 25 years ago. So if you came in about 20 or 25 years ago and say you had a heart attack, they would take you to the hospital, they would rush you there, they would crack your chest open, and they would do a bypass surgery. We don't really see that happening anymore. In rare cases where you need extensive aggressive therapy like that, absolutely. But in most of the cases, that field has evolved into interventional cardiology, where now, through again the head of a needle, using wires through a penny sized incision, they're going in and putting in spacers or extenders in your heart. So it's very similar. And so in my field, right, over the last 3 to 5 years, a lot of these technologies have evolved where we're actually coming in again through the head of a needle or through a penny sized incision and then putting in the kind of spacers that you and I talked about. So again, even with this kind of procedure, we're training other interventional pain physicians. All these technologies are FDA approved. We have a lot of research that shows how significantly that they can help. And in some situations, these are permanent fixes for patients. So they don't end up needing anything more extravagant. In some situations, they can be bridge procedures. What that means is that, okay, maybe you end up needing a larger surgery, but maybe you're not there for it yet. Or the surgeon says that, hey, Ms. Anderson, you do have some back pain, but you don't really need a larger surgery right now. So let's try something different. And this is where it also fits in. The other value that a lot of these minimally invasive options offer us is that they're done as outpatient procedures. They're done as a same day procedure. So instead of you requiring time in the hospital for recovery afterwards, you come in, we do the procedure, and you leave the same day. In fact, you'll walk out of that OR into your car and you'll go back home. And most of the recovery is a couple days to a couple weeks at most instead of several months. And then all of these procedures, we have extensive physical therapy and chiropractic follow up afterwards to ensure that you're walking alongside the correct path for full recovery.
Yeah, I'm glad you repeated that analogy to like cardiothoracic surgery and interventional cardiology, because I think that one, at least I'm more familiar with, right? Everybody knows about how you can get a stent in through your leg or even now your neck and help expand the vessels of the heart. And I think it's a good analogy to what you guys are also doing. And it's an important one too, because the recovery time, like you said, is way
Well,
faster. You're in and out same day.
the risks are significantly
Yeah.
less when you're doing that. And when we talk about these procedures, especially with cardiology, you've seen how quickly it's changed, right? And there was a new field that developed essentially called interventional cardiology. So when people often ask, Dr. Budwany, what's your specialty? I call it interventional spine rather than just interventional pain, because we are focused in a more dynamic way. There's a lot more tools that we have to help our patients. Another example I'll give you is for sacroiliac joint dysfunction. So this is typically the patient that comes in and they're sitting down for a period of time and they're like, hey, doc, when I sit, I can only sit on one side and I have to keep changing positions, right, frequently. Or if I'm driving right across the bridge, I can't sit too long. I can't go on long drives like I used to. I had a patient the other day, and they're like, we would go to Disney all the time, and now we're no longer able to do that because I just can't sit for that hour and a half that it takes me to get there. And I'm shifting positions back and forth. So what's happening is something called joint laxicity. The sacroiliac joint, it's the largest joint in your body. It becomes destabilized or loose after a while, especially in women who've given childbirth. And so again, that's part of normal aging, but pain and dysfunction should not be part of normal aging. And so previously, the way this was solved is that you would come in and you would work with the spine surgeon or orthopedic surgeon and get a larger surgery done, which may still be an option. But now there's minimally invasive options that we come in from the back. We put in a cadaver spacer in that little joint. And again, these are all done in the same day, outpatient procedures. And with a small scar the size of a penny, and that helps you with recovery. You go out the same day, and that solves the problem. So again, if you were afraid that, hey, I don't want to be intubated or put to sleep under general anesthesia, or I don't want that time in the hospital for recovery, now we have options that are allowing you to really recover much quicker. So again, that goes back to that interventional cardiology analogy that we're doing everything again through the head of a needle, through a penny-sized incision. And in fact, I have a model that I can show you. If you look at this, and this is part of your sacrum here, previously, if you had come in and you had to try to solve this problem, this area right here, this is actually the little tiny spacer that we put in. So I don't know if you can make it out. It's a really small spacer there. But that's what we put in to help keep the joints apart. There's material in there that actually helps to fuse that joint with time. So again, it's allowing you to recover much quickly because it's not too aggressive on the bones themselves. So again, this is one of the many options. It's not saying that you may not need a larger option. All it's saying is that you need to actually consider the other things that are available, because a lot of our patients are not aware that, hey, I have this problem and I don't want this larger surgery. I may have this minimally invasive option that's available. So again, it just depends on what you're reading out there. If you ever go to my website, which is painhealth.com, there's an extensive education library out there on all these different therapies that are there. And again, the goal is just to guide our patients down the right pathway so that it optimizes their performance and really reduces their time and pain.
Is the spacer in that case, if there's joint laxity in the SI joint, like decompressing the nerve that's going through that to help patients? Is that kind of what it's doing?
So, yeah, the part of it is that you want to stabilize that joint. It's the instability
Mhm.
that can cause it. So that part of it, fusion, right? People say, don't say the F word. It's not that we're not saying it. It's just helping people not to be afraid of it, because
Okay.
you need care. And whether it's a larger spine surgery, in many cases, if you need this in your neck or your lower back, then that's absolutely needed. The last thing you ever want is to be disabled, right? That's the last thing anybody wants. You just need to be aggressive and figure out, as a patient, be educated on what are the therapies that are out there that can help me, because the tools are there. We have more tools now than ever before. And these tools are becoming easier for the patient to actually undergo the procedures, and it's reducing, again, the recovery time. It's reducing the surgical time. And so these are all options that are there. The two tools that I mentioned here, these are all done actually at the surgery centers that we work with. And again, they're all done combining with our surgical partners in some cases, our anesthesiology partners there as well. Everything requires cardiac clearance just to make sure that the patient is the optimal candidate. But before we even consider any of these procedures, they undergo extravagant testing, so alongside imaging and physical therapy and those injections we do to pinpoint, to make sure that those are the joints, those are the nerves that are really misbehaving, and what can we do to actually correct it.
So before I move on to another half of this topic, was there anything else that you wanted to talk about more with the minimally invasive spine
Yeah,
technique?
there's a couple other options actually. So we're in a really unique era where your phones and your Apple Watches and your Google Glasses tell you all these things that are going on, especially with your health. And so I think we're in a time frame of wearable technology. So part of the approaches you talked about were pharmaceutical approaches to taking medications, or us even doing injections. And then we talked about the instrumentational approaches, putting in specific spacers and those kind of things. The other thing I want to talk about is actually the electroceutical approach. So you guys may have never heard this term before, but the electroceutical approach is essentially sending energy, or little microwaves of energy, to the nerves in your spine or to the nerves in your body, and directly talking to those nerves and turning off that pain signal. So it's really a unique field of medicine, which is a big part of what I do, where we basically put in little wires that are thinner than your hair. And I can put one up. I don't know if you can actually see this on camera. It's a little tiny thin wire here. And essentially, what this wire does is we actually come in and we put this wire, if you can see it here, we would put this wire in the epidural space in your spine, or we can put this wire next to other nerves that are acting up in your body. And it sends in micro signals to those nerves. And those signals talk directly with the nerve and basically bypass whatever short circuit that's there, or amplifying the pain. So it's, say if you had a short circuit in your house and the light flickers, right? Or it's misfiring. Very much, right? The pain signals in your body, because of overuse or because of neglect or because of direct pathology there, they can misfire. And so when that happens, what we found is that if we use this electroceutical approach, where we put the wire in there, it bypasses those bad signals, it turns off that pain signal. So again, this is more of a long-term fix. Now, the way this works in our clinic is we actually do a trial of this. So we don't go to a permanent procedure until we do a trial. So we put that wire in there temporarily, stays there anywhere from 5 to 7 days. And in that time, you're able to see how much relief you get. And the way you control this is simply with your iPhone. You actually have all the programming in your iPhone. It talks directly with it. And other than that, everything else is just in your body itself. The wire stays in your body, but you really don't feel it because it's a micro wire. It's thinner than your hair. So once it's implanted, you'll never know it's there. In some situations, and this, it's done as a wearable technology called a peripheral nerve stimulator. So say if you have shoulder pain or knee pain or ankle pain or hip pain, you can put the wire just over those nerves And in your garment, whatever you're wearing, you can actually have a pad that activates it. So it's like a wearable technology. Only when you are using it, it's active. In other situations, you actually implant a generator or a battery in your body. And the size of the battery is the size of basically $half. So this is how small that little battery is. And that's implanted in your body itself. That battery comes in several different forms. One is a non-rechargeable option where you can leave that in there for about 5 to 7 years and it's constantly active whenever you need it. In other options, you can recharge it about every 1 to 3 months. So there isn't a lot of burden on the patient. But what it's allowing them to do is that previously, when they were really left disabled because of that pain, they're no longer having to take oral medications and they're no longer having to come in for injections to manage that. We're able to use this electroceutical approach. And a couple of things I'm going to touch base on is a lot of patients we get are patients that have pelvic pain. So this is a big part of the patients that we see. And it's been previously very difficult to treat this. So either when people had difficult childbirths and they had scarring as a result of that, or they've had surgery done for prostate cancer, for example, and now again, they're having pain. A lot of those things, when they're having pelvic pain, this technology helps to turn that signal off. And so again, we would do that with a trial, or if they've had an amputation. That is another situation in which this technology works really well because anytime you have an amputation, it scarves the nerves that are there. And so this kind of technology actually helps to turn that pain signal off. Another situation in which patients do really well if they have something like peripheral diabetic neuropathy. And so that's really big because neuropathy is secondary to diabetes. And what happens in that situation is that those nerve signals are being basically impaired by the diabetes in your body. And so when you bypass it by putting in this wire, essentially, it communicates with those nerves. It calms down that hypersensitivity and turns that pain signal off. And so again, there's different ways to take this approach. That's another interventional approach that we take. But a lot of this is done, again, through the head of a needle in an outpatient setting. So the recovery is minimal, if any. None of these things require an overnight stay at the hospital.
I don't think I knew that you guys use that for diabetic neuropathy. I think that's nice to have other options because that's definitely one of the conditions where I feel like the medication is the band-aid and there's not much you can do, improve glucose control and things like that. Even with that though, have you ever seen like the neuropathy get better if the diabetes is very well controlled?
Yeah, I think so if you control, I think, like we said, pain is dynamic. So it's a lifestyle issue as well. Like you need to still continue to manage your diabetes, but
Mm.
the consequence of long-term diabetes, even if you get better, is the neuropathy that's there.
Mm.
And so this helps to improve that because the neuropathy is there because those nerves, again, their sensitivities change because of the diabetes. And so the only way to improve that is by sending a correct electrical signal because the way our nerves communicate in our body is through electrical signals. And so when we send these electrical signals, it really helps to reverse some of that. Like another example I'll give you is something called complex regional pain syndrome or CRPS. That's been really poorly treated for a long period of time because it was misunderstood and it was extremely challenging. In fact, it's one of the most challenging things we treat. So I'll give you an example. If a patient, say, had ankle surgery, right, and it fixed the structural problem because surgeries do a great job fixing the structural problem, but whenever you're doing a surgery, you're cutting through nerves, or whenever you had an injury, it's damaging the nerves that are there. And so these patients often see that their ankle or their joint, wherever they had that kind of injury, may swell up or be discolored. Right. So that's part of the consequence of that kind of injury. And what we've noticed is that when we actually put in this kind of therapy, this electroceutical wire, it actually reverses that discoloration, that bruising, and that neuropathy, and it helps to reverse it. So those are the different things to keep in mind that, for my patients, like I want them to understand there's so many different tools that we have that you don't have to feel like you're constantly suffering and there is no end game here. Like we have tools that don't require to undergo extravagant procedures. And a lot of these tools work extremely well so you can go back to your day-to-day life and function.
Does it improve the swelling? You mentioned the swelling. Does it actually do?
Because swelling is again a secondary consequence of
Mm.
the environment. So if there's hypersensitivity around the nerve, then the way we are communicating with the nerve and reversing that can help improve that as well.
Interesting. I would have thought that was just like a lymphatic drainage issue or something.
Part of it is that we're not just there's a
Like
lymphatic
venous.
that's
Mhm.
going to be there, but if you're seeing local hypersensitivity that's
Mhm.
happening, local inflammation, then those are the things that the electroceutical approach works really well on.
Is it a bad idea to also liken that to cardiology with the electrical pathways of the heart, where they have to ablate them if the signals become erroneous, like you were saying?
So it is. We spoke about doing diagnostic injections for that pain block. So we come back in and do something called an ablation, a radio frequency ablation, which is very similar to what electrophysiology does, is we're sending those signals to those nerves to dampen that misfiring of the pain pathways.
Perfect. Yeah. All right. So I want to ask if there are other exciting procedures that you guys do that I feel like we could go on, but are we missing any big things that you want to discuss before we go on to AI?
So we do a lot of headache management as well. A lot of people have significant issues with migraines.
We're going to pause here, but in part two, we're going to dive into the solutions and what patients can actually do next. We'll break down minimally invasive treatments, artificial intelligence in healthcare, and how patients can start getting their lives back. Stay tuned for part two next week.